Morning. Thanks, Ty, for the introduction. I don't usually do this, but I have to say, Dr. Scott, that was the best presentation I think I've heard in many years in regards to anticoagulation and ECMO, and unfortunately showed me all the things I've been doing wrong over the many years as well, but that's good. That's the information that we need to know. When I first entered perfusion back in 1980, given a unit of blood during routine cardiopulmonary bypass was a pretty simple thing. You'd send a result out, and if the hemoglobin was less than 10 grams per deciliter or 9, I'd order out a unit of blood and I'd give it to the patient, and probably 3/4 of the way through the case, the anesthesia would order another unit of blood and give the unit of blood to the patient. And at the end of the case, the surgeon would just ask us how much blood we gave the patient, and that was pretty simple. We knew about the hazards of blood, but we just weren't, that wasn't the era of all of the comorbidities and morbidities associated with transfusion. Then when I left clinical practice around 30 years later, I'd get a result back. I send off a result and get a result back, and it'd be 7 grams per deciliter, and I'd look at the result and I'd give it to anesthesia and say, what do you want me to do? And anesthesia would look at it and say, well, what do you think? And I say, well, I don't know. What do you want to do? And he would say to the surgeon, well, it's 7 grams per deciliter. Do you want a transfusion? And the surgeon would say, well, that's, you guys make that decision. That's up to you. It was like the hot potato game. Nobody wants to make a decision at that point. But the thing about back in the 80s is that you'd also send off a result, or you send off a sample to the lab, and you always knew you got a very accurate result, because that's what the lab did. They do a CBC, culture counter. You also get a hemoglobin hematocrit, and we relied on that. Very accurate results we used to get back from the lab. And the downside was it used to take about 30 to 45 minutes before you got a result. And unfortunately, many times our last blood gas patient would be on the way out of the OR, and we'd get our results back. But somewhere in the mid-90s, I'm not sure the exact number, we started seeing point-of-care analyzers showing up in the operating room, and that was tremendous from my perspective, from every clinical perfusionist's perspective. That was a tremendous bonus that we could now look at our level of hemodilution within 2 minutes. We could look at the electrolytes, we could look at lactates, acid-base balance, and it really changed the way we practice. It made a tremendous difference in the way we practice and manage patients. If we'd had anything like data collection systems back then, you would have seen big gaps in the thing. Charting was appropriate back then because there was long gaps in analyzing. But when these devices came in the operating room, the one thing that we noticed is that there was 2 types of technology that were being presented to us. One type of technology looked at total hemoglobin and given us our results in total hemoglobin. The other technology gave us our results in hematocrit, measured hematocrit. And back then, we weren't quite sure which one was the most accurate and which one had some inaccuracies. And so I published a paper. I did a review article on the 2 technologies. I published a paper in 2007, had it printed in Perfusion in England. And with that particular paper, it was well accepted, well downloaded. It showed the differences between the 2 technologies and what to expect and what you couldn't expect. And so from that perspective, this is where I want to take you in the first part of this particular presentation. I want to give you a little review of the 2 differences, or the differences between the 2 technologies, because they still exist, and they've existed for many years, been around for a long period of time. So just give you an idea of the 2 technologies, and then halfway through I'm going to switch to a study that we just completed in December 2016, a retrospective analysis study, and show you some interesting data that you might find informative. First of all, just give you a little disclosure. As I said, I've been in perfusion over 37 years. I left clinical practice in 2010, and I have a consultancy company I call International Perfusion, and I consult with 3 different companies now: Instrumentation Laboratories, Livanova out of Italy, and another company called Clearline MD out of Boston as well. So the one thing that we have to keep in mind is that when we're talking about cardiac surgery, a difference of only 1 gram per deciliter in hemoglobin can really make the difference between us giving a unit of red blood cells and that patient not receiving a unit of red blood cells. I mean, that's a pretty simple statement to make, and that can apply to every type of surgery out there, but it's specifically relevant to what we do, because we have patients that come to us in the operating room. 25 to 37% of those patients that show up in the operating room are anemic. They come into as a state of anemia. Those patients have predicted poor outcomes, and they have an increased, well-documented increase in transfusion related to their preoperative anemia. We also use a tremendous amount of fluids. We use crystalloids and colloids. We take the blood off, we spin it, we get rid of the proteins, we use hemoconcentrators. So for us, the difference of 1 gram per deciliter makes a big difference. And through outcome studies that have been done over many years, randomized controlled trials, we know that there's certain levels that if you keep the hemoglobin above it, that's got to do with goal-directed perfusion as well. If you keep the hemoglobin above a certain level, those patients tend to have better outcomes, tend to have less transfusions. So that's where we operate. That's how we operate in the cardiac operating room. And for us, that's a very important parameter to understand, that 1 gram per deciliter can make that difference between them getting a unit of red cells with all the comorbidities that's associated with it and those that don't get a unit of red cells. The latest data that's come out has come out in the Cochrane database of systematic reviews. In fact, it just came out in October last year. And as you know, anybody who knows Cochrane data, the Cochrane database of systematic reviews, it's a very prestigious organization, and all they look at is randomized controlled trials. And in this particular case, they looked at 31 randomized controlled trials over 12,000 patients. And they demonstrated with those randomized controlled trials that if you keep the transfusion thresholds between 7 and 8 grams per deciliter, you can increase, or you can decrease the incidence of red blood cell transfusions by as much as 43%. That's pretty significant. The AABB has adopted that as their recommendations for transfusion guidelines as well as of December of last year. When we're talking about red blood cell transfusions, if you go back to 1996, back then it's reported that there was over 12 million units of red blood cells that were transfused annually here in the United States. By 2012, that number of red blood cell units had gone up to over 15 million units of red blood cells. Now in cardiac surgery, that translates to about 10 to 15% of those units of red blood cells that we use in cardiac surgery. On a global basis, in 2012, there was about 85 million units of red blood cells transfused, so that made up about 18 to 19% of the transfusions. The global transfusion of red blood cells was done here in the United States. And the cost at that time was estimated to be over $2 billion when you're talking about the costs associated with the transfusion, using the data that they had at the time. We also know there's a lot of unnecessary and inappropriate transfusions that goes on. In regards to unnecessary transfusions, we know they can be as high as 18 to 57%. That's a lot of transfusions that people get that are going to have comorbidities that are going to be associated with it down the line. And when you're looking at the costs associated with it, it's estimated that 25% of the costs of red blood cell transfusions can be attributed to these inappropriate transfusions. So if you just do some rough math, 25% of $2 billion, that's a tremendous impact on the healthcare system. And that's only with transfusion of red blood cells. That's nothing to do with the comorbidities associated. We will cover that in the next slide. But that's just with the transfusion of red blood cells alone. So the financial impact of red blood cell transfusion comes down to looking at the costs associated with it. Now, we know that here in the United States, you can buy or purchase a unit of red blood cells, from what I'm told, around $300 or $400, somewhere in that range, depending upon your supplier. But Ari Shander, as you all know, he's a big name in transfusion medicine. He took a look at the costs associated with it, and he said you have to also, and we all know, we have to consider the costs of collection, storage, processing, testing, and all those things. And when you put those costs associated, it can be anywhere between $522 and $1,183 for that one single unit of red blood cells being transfused. And that gets added every time you give 1 unit of red blood cells to those patients during routine cardiopulmonary bypass. When you look back and you take a look at Lepar and co-workers in 2013, they actually looked at the incremental costs that are associated with red blood cell transfusions. If you take a look at their data and says that in regards to the intraoperative transfusion costs, it can be as much as $4,408 for the associated costs with red blood cell or not red blood cell, but blood product transfusions. And if that transfusion takes place in the postoperative period, it can be as much as $10,479. Now, you look at those numbers and you kind of think that, well, they're pretty exorbitant, they're pretty high where they come from. But if you actually take a look at one extra day stay in the intensive care unit, it can be $7,000 or $8,000 just for one day stay. One extra hour in the operating room can be as much as $2,000. So just waiting for products to come during the process of transfusion prolongs those processes. So it's not difficult to understand where these costs associated with transfusions come from. Now, when we're talking about total hemoglobin analyzers like Co-Oximeters, these are modern Co-Oximeters that they use spectrophotometry, they use light waves to analyze the hemoglobin moiety, the heme molecule, and they analyze the 4 hemoglobin molecules or the 4 hemoglobin chains to get what's called the total hemoglobin. What I like to throw in at this particular point is maybe a bit of useless information, but it's interesting to me in the sense that you talk to people and some people have the impression that you have one red blood cell and you have one hemoglobin molecule. But in fact, you have between 250 and 270 million molecules of hemoglobin in every red blood cell. And if you take the consideration that each one of those hemoglobin molecules can carry 4 molecules of oxygen, that means that one red blood cell can carry over 1 billion molecules of oxygen. I mean, it's a it's amazing system. So when you're talking about total hemoglobin, you can break it down into two different types. You've got functional hemoglobins and you've got dysfunctional hemoglobins. Now, the functional hemoglobins are made up of what's called oxyhemoglobin and deoxyhemoglobin. As you all know, the oxyhemoglobin is that portion of the hemoglobin molecule that delivers oxygen to the tissues, and the deoxyhemoglobin is, once it's released, it's in that particular format. The dysfunctional hemoglobins are called carboxyhemoglobin and methemoglobin, and we'll talk about those next. But carboxyhemoglobin is when you're exposed to carbon monoxide that combines with the hemoglobin molecule, and methemoglobin is when you actually have a breakdown of the hemoglobin molecule. It changes from a ferrous state into a ferric state. It loses an oxygen molecule, and because of that, it becomes really hemoglobin, doesn't carry oxygen well, so it's really useless hemoglobin to us. So normally the oxyhemoglobin and the deoxyhemoglobin make up about 98 to 99% of the hemoglobin molecule itself. The other 1 to 2% is always carried in the form of methemoglobin or carboxyhemoglobin. Now, everybody in this room has a level of methemoglobin, and we have a level of carboxyhemoglobin. The methemoglobin just comes from the natural cellular breakdown of our red cells, and it's normally less than 1%. But you can have, there's a number of things that can cause your methemoglobin levels to go up. One of the things is genetic factors. If you have a genetic propensity to it, can cause methemoglobin levels to go up. Exposure to anesthetics like benzocaine and lidocaine. There was actually one report out there where a gentleman showed up in the emerge department. His lips were blue, his fingers were blue, he had trouble breathing, and they found his methemoglobin levels were extremely high. And what he'd been doing, he's been using lidocaine to pack a sore tooth that he had, but he absorbed so much of it, it just causes methemoglobin. It's also related to when you're given sprays for intubating patients. It's a topical anesthetic. So all of these things can cause methemoglobins go up. Chlorates, things like explosives and fertilizers. I always joke around saying that those are good things. They should have them in airports, so that if you got to suspect anybody's been around explosives, do a blood test on them and see if their methemoglobin levels are up. But I had a patient many years ago who he had a high methemoglobin level, low oxygen saturation, no indication to it. We found out he was a farmer. He was exposed to a lot of fertilizers. And exposure to things like volatile nitrates, nitroprusside and sodium nitrates, the drugs we use, the therapies, nitric oxide therapy that we use also relates to high methemoglobin levels. When it comes to carboxyhemoglobin, the normal level is less than 1.5%. And you can have higher carboxyhemoglobin levels. You don't become symptomatic with carboxyhemoglobin levels until they get above 10%. Things like lethargy, confusion, those kind of things. if you have a person who's a heavy smoker, they can have carboxyhemoglobin levels as high as 12%. We don't start treating methemoglobin level or carboxyhemoglobin until it starts getting up around the 25% range. But some of the things that cause it to go up are, as I said, heavy smokers, people that are exposed to combustion engines, auto mechanics in closed areas. And one of the things that often gets unrecognized is you can have high carboxyhemoglobin levels in banked blood. In fact, you can have carboxyhemoglobins in banked blood as high as 12%. Now, that may not be a significant bit of information that's important to transfusion you or I, but when you're talking about neonates, you're talking about infants, that does have a significance, especially when you're talking about the different types of the infants we treat, like the acyanotic and the cyanotic infants. The cyanotic infants, they live on low levels of oxygen. And then if you start transfusing them banked blood that's got high carboxyhemoglobin levels, you're going to interfere with acid-base balance. You're going to have a problem with those patients coming off bypass. So the program that I was at, we implemented a process that every unit of banked blood we gave to infants, we would always take a sample of the blood first and then run it through the co-oximeter. And I think we found one, maybe two over the years that had high levels, and we just sent it back to the lab. So it's one of those little things that can slip by you if you don't recognize it. Without a co-oximeter, you would never know it. There's no way of ever knowing it. So we know that total hemoglobin is very accurate. Anybody, like I was a respiratory therapist for 8 years prior to being a perfusionist, so I'm not as young as I look. But Shapiro is a name, it's a big name in respiratory medicine and acid-base balance and oxygenation, and anybody who's in respiratory medicine knows about Shapiro. And he said that the co-oximeter is the most accurate method available for measuring the 4 clinically relevant hemoglobin moieties and is considered the standard against which all other methods must be compared. So we know total hemoglobin is accurate. There's no question about it. Where it's done, whether it's done in the lab or whether it's done in a point-of-care analyzer, we know it's an accurate measure of hemodilution, which is what we need. I mean, all of the talks that you hear before my ones and you'll hear throughout the day, the importance is on accuracy. We have to be accurate in what the results that we use, because that makes us, that provides us with the ability to give better clinical making decisions to our patients. So the other type of technology that entered the OR back in the mid-90s was conductivity or hematocrit technology. Now we know that conductivity devices, that what they do is they measure the hematocrit, and then through a series of algorithms they calculate the hemoglobin. That's the way they're based. Conductivity itself is just it's a measure. It's done through passing a current through a blood sample, and the resistance it meets. That's what determines the hematocrit. Conductive hematocrits are relatively accurate under most normal physiological conditions, but not when the proteins and the viscosity are altered, such in cardiac surgery or ECMO or whatever the case may be. And the one thing I want to stress when I'm talking about the technologies I'm talking about here, I'm not just talking about the cardiac operating room, I'm also talking about the cardiac intensive care unit, because we can't separate what we do to the patients once they leave the operating room, because we've altered their rheology, their physiology in a tremendous way, and that carries over into the intensive care unit. So when I'm talking about analyzers in one unit, if you have one type of analyzer in one space and one in another, you're going to probably have some conflicting results that you may not want. But the thing that always bothered me about this particular term is that in most normal physiological patients, but I really don't know what normal physiological patients, I mean, I've been in healthcare a long time, and I do know that once you enter the emerge department, the first thing you're going to get is a liter of fluid, or you're going to get 2 liters of fluid if they figure you're dehydrated. Or if you're in some other area of care, you're going to get some sort of fluid. So immediately when you get, I mean, if you get 1 liter of fluid, you can drop a patient's hemoglobin, a 70-kilogram patient, by as much as 2 grams per deciliter. So when you're getting these fluids, it doesn't make you normal anymore. So I really don't know what they mean by normal. You're going to alter viscosities, you're going to alter protein levels. This is something that I didn't make this up. I just downloaded it from their website. It's the same thing I put on in the previous paper that I published in 2007. I put the link in the published paper. The link is not there anymore. This is a new link. I had to go find where the new link was. But it's a simple statement that's put out by Abbott Laboratories. I think they sell the iStat device. And what they said is, they said that hematocrit results are affected by the level of total protein, such as those undergoing cardiopulmonary bypass or ECMO, and those patients receiving large volumes of saline-based IV fluids. Well, that really talks about what we do, a lot of the stuff we do. They also state that factors that affect sodium will also affect hematocrit results. And the final statement they make is that the CPB algorithm used in conductivity assumes that cells and plasma are diluted equally and that the pump priming solution has no added albumin or other colloid or packed red blood cells. Now, I'm sure everybody here who's been doing perfusion knows that your pump priming solution is going to contain either a colloid or crystalloid or maybe even a blood product at some point, whether that colloid is synthetic or whether it's natural. So that's kind of a broad assumption to use. And the way they correct for it is they correct for it by using algorithms in that particular cells. One of the things that they do with the iStat device is they have what's called a CPB mode. And the CPB mode is basically, it's another algorithm that's put in, and it's based on the assumption that the protein levels in these particular patients are going to be at a certain level, and it sort of mathematically tries to correct for that protein decrease. But the problem is patients that come to the operating room, we have no idea what their protein levels are. We don't know what their protein levels are going to be when we leave. So there's a lot of guesswork in that again. So what are some of the problems that's associated with conductivity during cardiac surgery? Well, conductivity readings can be altered by many factors, and they can give you a false high or they can give you a false low value. Things like increases in sodium and decreases in protein concentration can give you a false low value. Decreases in sodium can give you a false high value. Anticoagulant types and concentration, which we use a lot of, and we use a lot of different types, can give you a false low reading because it affects the sodium. Increases in concentration of leukocytes gives a false high. The use of volume expanders, which we use a lot of in cardiac surgery, gives you a false low. And even the increased lipid profiles can give you a false high value. The interesting thing about lipid profiles is that, as we all know, I mean, that's why a lot of patients come to us, because they have such bad lipids, they have coronary artery surgery. But the other thing that's used very frequently in cardiac surgery that we don't take consideration of is propofol. Propofol is a lipid-based drug, and depending on whether you're using a low-dose strategy or a high-dose strategy, propofol is a lipid and can affect your results. So there's a lot of things that can give you false low and false high values using that particular device. I'll just give you 3 particular papers here to sort of give the importance or the thought process around conductivity. If you look at one of the more later ones, Anesthesia Analgesia 2012, conductivity-based hematocrit point-of-care devices should be used cautiously, or should be cautiously interpreted when hemodilution is present. That was the more recent one. One that comes back from 2004, quite a while ago, said that conductivity results are lower than laboratory results that use a hemoglobin analyzer, with discrepancies between 1 to 2 grams per deciliter for hemoglobin at its lowest protein concentration. As I said, one difference of 1 gram per deciliter can get you transfused. But if you go way back until 1990, even back then, it says conductivity will report falsely low readings in situation where plasma has been replaced with crystalloid. So we've known this for 30 years. We've known this for a long time, but we still employ it. We still use it in our practice. So the question has always been, well, what difference does it make? We know the scientific literature contains many references about the inaccuracies and limitations of conductivity hematocrit-based point-of-care analyzers used during cardiac surgery, but there's zero evidence or there's no literature to dispute the ability of co-oximetry point-of-care analyzers to accurately measure total hemoglobin values during cardiac surgery. So I bring back to you the thought process of so what? You know, I mean, so what? You got a total hemoglobin analyzer doing your stuff, and you got a hematocrit analyzer doing your stuff. You're tracking the patient's levels throughout, and if you got a problem with the conductivity with low levels, then you send off to have a total hemoglobin done in your lab before you give a transfusion thought. So that's really the thought process we've been basing our things on. We've known for years that one has inherent inaccuracies with it. We know one is very accurate. But so what? Until we finished this particular study we just did. Because what we did is we looked at, this is an outcomes-based study, and this particular study was looking at patients that were managed with total hemoglobin and patients that were managed with hematocrit. We've presented this paper to Perfusion in England. It has been accepted for publication. It's just going through the change process now, and it should be out within the next couple of months, hopefully. This particular paper really is something that puts a little bit of a different light on in regards to the two technologies. So the paper, you have to understand, like I said, I'm a consultant, and this paper, the funding for this particular study was done through instrumentation laboratories, but the company that did it was a company called MedAssets. MedAssets is a health analytics group. It's a massive health analytics group, and in fact, they've got their own group within MedAssets called Health Data Analytics. It's a data mining group. So for those of you that don't know what MedAssets are, is that they're a nationally recognized healthcare technology company, provides billing details through its administrative databases for over 400 hospitals across 43 states in the U.S. The data that was acquired for this particular study was done through the Health Data Analytics group, and it was done between a period of 2014, January 2014, and June of 2016. What we found is we found over 18,169 patients to be included in this group. All of them were over 18 years of age. They had to have three categories in order to be in the study. They either had to have coronary artery bypass graft surgery, or CABGs obviously, or valve replacement, or combined procedures, CABGs and valves. The study was broken up into two separate cohorts. Those patients that were totally managed with total hemoglobin analyzers throughout their stay in cardiac surgery, and those patients that were totally managed with conductivity throughout their stay in cardiac surgery. Any patients that had both technology used were excluded from the study. For example, as I said, you have one group use total hemoglobin, you have another group use conductivity, so they were excluded from the study. We didn't want any interference with that. What we found is that out of the 18,169 patients, 34% of them fell into the total hemoglobin group. And out of the 18,000 patients, 12,000 of them fell, or 66% of them fell into the hematocrit group. When we look at the demographics for between the patients, it's something that we fully expect what we would find anyway, is when we look at the female population, 29.8% of the hemoglobin group were females and 30.3% of the hematocrit group were females. And with the males, 70.2% of the hemoglobin group were males and 69.7% of the hematocrit group were males. Given that 70-30 divide, which is, we've basically known that all along, but just verifying that data. When we look at the age of the patients, the mean age for the hemoglobin group was 65.02 years, and the mean age for the hematocrit group was 65.85 years, reaching statistical significance. So what we looked at the primary and the secondary outcomes of interest in this particular study. The primary area of interest was on red blood cell transfusion, and the secondary interests or secondary outcomes that we looked at were hospital costs and hospital length of stay. What we did to get that, we used risk-adjusted associations by estimating by using a multiple regression analysis on the data that was collected. We looked at comorbidities because we want to measure all the comorbidities, of course, in the retrospective analysis, because you want to mitigate or reduce the potential for confounding of the risk of red blood cell transfusion. We also looked at what's called the Charlson Comorbidity Index when we looked at these patients. And the Charlson Comorbidity Index is a measurement of about 15 different comorbidities that are related to the early death of the patient within a 1-year period. And the higher the comorbidity index in the Charlson Comorbidity Index indicates that these patients have a tendency to die earlier within a 1-year period than the others. And it's a common data analysis that's done when you're looking at administrative databases. And those that were measured with the total hemoglobin group tended to have a higher Charlson comorbidity index than what the ones in the hematocrit group. And they look at things like cancer and those kind of things, that chronic obstructive pulmonary disease that can lead to earlier demise. We also looked at the comorbidities that increase the risk of red blood cell transfusions, such as whether or not the patient was on pump or off pump. And if you look at those patients that in the hemoglobin group, 84% of the patients in the hemoglobin group were done on bypass, and 87.4% of the hematocrit group patients were done on bypass. And all of these reached statistical significance. Excuse me. Intravenous iron. We know that they received intravenous iron. They were probably anemic. That's why they got to receive the iron. 8% of the hemoglobin group received intravenous iron, and only 2.5% of the hematocrit group received intravenous iron. In regards to severe bleeding, somewhere during their perioperative stay, 4.6% of the hemoglobin group had severe bleeding, and 3.9% of the hematocrit group had severe bleeding. Those patients that are dehydrated, obviously the more dehydrated you are, the more fluid you're going to receive. Those patients that were dehydrated, 3.7% of the hemoglobin group were dehydrated, and only 1.5% of the hematocrit group were dehydrated. Those that were hypertensive, 58.1% of the hemoglobin group were hypertensive, and 53.5% of the hematocrit group were hypertensive. Exhibiting renal failure, whether it was stage 1, stage 2, stage 3, any form of renal failure, 17.7% of the hemoglobin group had some form of renal failure, and 16.5% of the hematocrit group had some form of renal failure. Looking at the hospital characteristics of where these devices were used and in what centers they were used in, we can see that looking at the teaching status, whether it was a major teaching hospital or a non-teaching hospital, we can see that 51.1% of the hemoglobin group were measured in major teaching hospitals, and only 13.1% of the hematocrit group were measured in major teaching hospitals. 26.3% of the hemoglobin group were done in non-teaching hospitals, and 37.8% of the hematocrit group were done in non-teaching hospitals. And then we looked at the bed size for the hospitals, whether they were less than 100 beds or whether they were major centers of 500 or more beds. And we see that 5.3% of the hemoglobin group were done in less than 100 beds, and 3.3% were done of the hematocrit group were done less than 100. And when we looked at the major hospitals, the big ones, 51.3% of the hemoglobin group were done in hospitals with more than 500 beds, and only 30% of those of the hematocrit group were done in those same hospitals. It more or less really showed us that the total hemoglobin 10 technology tended to be used more likely in major teaching hospitals, and also in those hospitals with 500 or more beds. Open heart procedures, CABG, there's no significant difference between CABG surgery or valve surgery. The only difference was we looked at CABG and valve surgery. 8.9% of the hemoglobin group was in CABG or combined procedures, and 10.4% of the hematocrit group was in combined procedures. So to get where the rubber hits the road, we look at the unadjusted results for red blood cell transfusions. Out of the total hemoglobin group, 18.9% of that total hemoglobin group were transfused, and in the hematocrit group, 20.9% of that particular group were transfused with red blood cells. We don't know whether that was one unit or multiple units, but they were transfused. So when you do the adjusted results for those red blood cell transfusions, and this is after controlling for patient hospital characteristics and patient comorbidities, we can see that with all CABGs or all populations combined, with an odds ratio of 1.26, this translates into a 26% risk of increased red blood cell transfusion with those patients managed in the hematocrit group. Hospital length of stay, the unadjusted results were those patients in the hemoglobin group had a mean stay of about 10.36 days, and those patients in the hematocrit group had a mean stay of about 10.43 days, which didn't show any statistical significance. But when you correct the results or adjust the results for patient hospital characteristics, patient comorbidities, and red blood cell transfusions, you can see that combining all of the populations above, we broke them down into each category, but combining all the populations above, once again, it had an incident rate ratio of 1.08, and that really translates into an 8% increase risk for increased length of stay in the hematocrit group. Hospital costs. When we take a look at hospital costs in the data, this is the unadjusted results, we see that the mean cost for surgery in the total hemoglobin group was $41,127, and the mean cost for surgery in the hematocrit group was $43,564. But when we corrected the data for patient hospital characteristics, patient comorbidities, red blood cell transfusions, and the length of stay, we can see that translates into a 15% risk for increased hospital costs in the hematocrit group with an incident rate ratio of about 1.15. So how does that break down into numbers? The risks that are associated with hematocrit management. We have to understand that when you're looking at all population, there's a 26% increased risk for transfusion when you're managed with hematocrit technology. There's a 15% increase in the costs of healthcare when you're managed with hematocrit technology. And there's an 8% increase in the length of stay when you're managed with hematocrit technology. And just to break that into something that's even more visible, there's 6% increase in receiving a red blood cell transfusion when you're using conductivity to measure hemoglobin dilution. There's an 8% increased risk of having a longer length of hospital stay. That averages out to about 0.8 days when you're using conductivity to measure hemoglobin dilution. And there's a 15% increased risk of having higher hospital costs, which amounts to $6,539 when you're using conductivity to measure hemoglobin dilution. Conclusion, the use of total hemoglobin technology in cardiac surgery was found to significantly decrease the risk of red blood cell transfusion, length of stay, and hospital costs when it was compared to hematocrit technology. And I'd just like to state that this is really the only outcome study that's ever been done in cardiac surgery that I know of to link those patients that were treated with total hemoglobin technology and those patients that were treated with hematocrit technology. And finally, just the last thing, I'd like to put a couple of limitations in here, is that these results suggest a strong association between total hemoglobin monitoring and a reduction of red blood cell transfusions, length of stay, and hospital costs in this patient population, but they do not imply causation. The study does not account for the presence and differences in hematological expertise, variances in physician preferences and their experience, program transfusion thresholds, or programs designed to minimize perioperative blood loss. But finally, we've got some evidence that shows that there's a little more than just being a difference in technology. It may have an actual impact on your patient outcomes. With that, I say thank you and look for any questions.